Hi, my name is Leila. I'm a Chief Fellow at UCSF. We're here at the ACC Conference in New Orleans. And today I have the honor of speaking with Dr. Michael Ackerman, who has a late-breaking clinical trial that is being presented here at the conference. Thanks for joining, Dr. Ackerman, for your time.
It's great to get to be with you, and we're excited to be presenting this work in just a couple days.
Could I ask you to first start us off with a brief introduction about what it is you do?
Sure. Well, I'm a genetic cardiologist at Mayo Clinic in Rochester, Minnesota. I serve as director of the Mayo Clinic Winland Smith Rice Genetic Heart Rhythm Clinic and the Winland Smith Rice Sudden Death Genomics Laboratory. And our program is devoted to families, young and old, at risk of sudden cardiac death from a variety of genetic heart diseases, mostly on the channelopathy side, long QT syndrome, but also on the cardiomyopathy side with HCM and arrhythmogenic cardiomyopathy.
That's so great. Tell us a little bit about the research question you asked in this study and how you thought about going to address it.
Yeah, well, this analysis of elite level athletes was born out of our experience at Mayo Clinic, where I currently follow personally over 800 athletes with a variety of genetic heart diseases, mostly long QT syndrome. And 2 years ago, we published our experience in JACC with those. And after that experience, the question came out, yes, you have a lot of athletes, but they're probably all little leaguers, middle school, high school. Do you have any who are seriously good? Are they elite level athletes? And we do. We have quite a few. But with that question, we said, you know what? We're not the only program that embraces shared decision making among our athletes, whether they're elite or just little league. Why don't we gather up our retrospective experience among those centers? And so I reached out to Dr. Matt Martinez and Aaron Baggish, then at Mass General Hospital, and Dermot Phelan. And we put together our past tense experience of all of the athletes under our watch who satisfied the definition of being elite, which we defined as making it to Division I university level sport or Olympics or professional level sport. And so actually, Dr. Matt Martinez's daughter, Kate, who is not yet even in medical school, she was a summer between her years of college at Loyola. She spent the year and the summer in my lab doing this analysis and working with one of my lead clinical investigators, Dr. Martijn Bos, to put together this retrospective study.
That's fantastic. It's such an important topic, and obviously it's come up in the news quite a bit too, is the safety of athletes as far as cardiac conditions and being able to play at a top-notch level. Could you tell us a little bit about the findings of the study?
Yeah, so we're really excited. It's not a surprise to me because I'm taking care of most of these athletes, not all of these because this was from all of us, but we have 76 who made it to the level of elite. And if you think about it, that meant that they had to have met either a shared decision-making minded cardiologist quite a long time ago to be able to progress and get that good, or many of these didn't even know they had one of these genetic heart conditions and they were flagged by the screening drill, by a screening program. So we have 76. 2/3 are Division I university, 1/3 professional ranks, and among them, men and women, more men than women, all sports represented. If you think about the different sports, 1A, bowling, cricket, curling, golf, riflery, all the way up to 3C, we had a lot in a lot of those categories of a lot of 2Bs, basketball, hockey, and so forth. So all levels of sports doing it, and 3 events of 76 elite level sports, through 50% HCM, 25% long QT syndrome, the rest. And it was uno, dos, tres. 3 athletes during this follow-up who had non-lethal events during the course of this study. The others, nothing. And most of these athletes, importantly, don't have an internal defibrillator. Less than 1/3 actually had their disease assessed risk assessed to need or compel an ICD recommendation as part of their treatment configuration. So most of these 76 Division I university professional athletes being managed without an internal defibrillator.
So relatively rare occurrence for there to really be a cardiac concern at all in these athletes.
I think that's the point. Now, 2/3 were caught in an incidental screening program. So in the sense that they were asymptomatic. So again, generalizable to the athlete who's already declared himself, or the person who's declared themselves with a sudden cardiac arrest survivor, we better be careful because we don't have as many of those. But I think what it tells us is that most of the events that happen in people with genetic heart diseases, whether HCM or long QT, they happen in an undiagnosed and therefore, by definition, an untreated state. After you're diagnosed, risk stratified, and carefully treated, whether you're an athlete or an artist, you can live and thrive. And I think this is going to challenge sort of the dogma that has been changing, but we've been entrenched in a dogma for 3+ decades of, if in doubt, kick you out. You're disqualified. You're not going to get to play. I'm not signing your return to sport. And 55% of these elite athletes, before they came to one of the four of us, they in fact had been disqualified from their sport and their activity.
That's such important work, and as you pointed out, will be very meaningful to athletes to come. Now, this was a retrospective study. I understand you're also doing a prospective study looking at the same question about return to play in these high-risk athletes. Could you tell us a little bit about that prospective study?
Yes, so we have a prospective study that, if you will, is being presented on Monday as well as a late breaker with Dr. Rachel Lampert from Yale sharing our results of our 3-year NIH-funded prospective study with people, not just athletes, just people with hypertrophic cardiomyopathy from age 10 to 60 across all levels of being active, from vigorous exercisers to the most sedentary. And again, you're going to see there good news, no difference in event rates among the most vigorous exercisers versus the most sedentary. Now, the athlete portion, that has been launched with a study called ORCA, ORCCA, for Outcomes Registry and Cardiac Conditions in Athletes. And we're looking to track all athletes in collegiate sports, in Olympic level participation, in the professional ranks in North America initially, and we may end up going global with that. But that's really the brainchild and the launch of Dr. Jonathan Dresner out in Seattle, Washington, and I have the privilege of being on the core committee of ORCA, along with others like Matt Martinez and Rachel Lampert and Aaron Baggish as well. And so they're out there, and if they're out there being returned to sport because they met a shared decision-making minded cardiologist, then we ought to ideally know of them and be very willing to report what we're observing, because we have to make sure that it's safe, and we have to determine ultimately, is it generalizable? Because we have to be careful there, because so far the great results have come from places that have devoted themselves and their careers to genetic cardiology, sports cardiology, all of the issues with respect to these specific genetic heart diseases. And we don't know yet how generalizable this experience is going to be.
I want to ask you a question about this realm of sports cardiology clinically, because as you pointed out, it's very specialized and it's not everywhere that there's going to be a multidisciplinary team taking care of patients. So at the Mayo Clinic in particular, if you have a high-level athlete who comes in, could you just give us a sense as fellows, who all are they seeing, and is it multiple cardiologists? What does the workup look like for them?
Yeah, it depends, and there's different models of sports cardiology, but I think the most important model is to have one and to recognize that sports cardiology is indeed, ACC recognizes it, that it is a bona fide subspecialty in cardiology, as worthy as much sort of focus and attention and recognition as any other aspect of cardiology. It's a boutique collection of patients. It's a boutique collection of diseases, and not every cardiologist can be versed in all of the nuances that go into what does it mean to return to play at the little league, high school level. How does that change when you go from shared decision making to a business decision making model called professional sports and Division I sports? And so it's nuanced. And I guess the point of sports cardiology should be, let's say a general cardiologist is wired to, I don't know about that. I'm not comfortable with letting you play. In the past, it was, you're disqualified. Maybe now it can be, I'm uncomfortable letting you play, but let me get you to a specialist for your situation. And that specialist is called either a sports cardiologist or a genetic cardiologist. And the different programs have different models, seeing the disease specialist and then intersecting with maybe the sports physiologist or the cardiac physiologist, working together, potentially psychology and dealing with the shared decision-making elements of the why. Is the return to sport, as I like to describe it, is it O oxygen or is it O optional? And helping families unpack that, whether they are adult age and don't technically need mom and dad's permission, but having the family unit on board and all the elements that go with that. And so every program is different, and a lot of sports cardiology is not tailored to the high school, college level. It's more of the 40-year-old, 50-year-old who wants to stay active, has coronary artery disease, and that's a completely different element of sports cardiology. This one of sports cardiology as it relates to elite athletes at collegiate level and professional level has a whole another set of issues and challenges, and it just needs, these patients, families deserve a sports cardiologist or a genetic cardiologist.
It's such a fascinating subspecialty within cardiology that's just taking off. Well, thank you so much, Dr. Ackerman, for your time. For more videos like this, please check out our YouTube page, youtube.com/fitsonthego.